All right, good morning, everyone. Welcome to this fine winter morning. Hope everyone braved the cold and made it here okay. We are going to pick up with some new material today, starting in on joints. And I want to just remind you that the material we cover today will not be on your exam. I'll talk a little bit more about the exam later, but this will go with the next unit. And this actually pretty much wraps up what we're going to cover with the skeletal system. We'll start talking about the heart next week. Before we jump into things, just a quick reminder, there is a cool seminar coming up this week on Tuesday. I'm looking forward to seeing this talk on the variation in color in these lizards here. They're very cool. It's free and open. There's going to be snacks. It's at 4:10 on Tuesday in the Science Center. So check it out. Spread the word. I think it's going to be really great. So our agenda today looks like this. I'm going to debrief your couple recent quizzes, your lecture quiz and your lab quiz that you took this past week. We'll talk about your ticket out from Wednesday. And then I want to just wrap up the appendicular skeleton. I have just a couple slides talking about some disorders of the appendicular skeleton. And finally, that human anatomy in the news that I've been teasing all week, we're finally going to get to today and talk about some sesamoid bones in your knee. Then we'll get into joints, and we'll see how far we get with this today. And this is perfect because this is what we'll cover in lab next week as well. And then I just have some reminders and your Friday Venn diagram. Notice there's no ticket out on there today, which is weird, but there's none. You're not submitting anything from class today. Cool. All right, let's talk about lecture quiz number 2. So this is a histogram of the results. This is the quiz you took online over last weekend. And you can see here the scores on the x-axis. The y-axis is the number of people that got that score. So you can see that, like, I think about 9 people got a perfect score on it, and so on. The class average was 28.3 out of 30, which is about 94%. So good job with that. If your score is falling out on this end of the distribution, might be worth stopping by office hours, going to tutorial, checking in with me to see kind of what you could do to get your score up here. Overall, the class did really well on that, and it tells me I need to make my quizzes harder, which I did with lab quiz, where you see your distribution of scores on your lab quiz here. So this is the histology quiz you took last week. Here you see a much more kind of normal distribution. The mean was a 7.3 out of 12, which is 63%. You can see a couple people in the class got a perfect score on the quiz. Most of you got somewhere kind of in the middle there. So just think about where you're falling in this distribution. Think about your lab score. Remember, the lab component is by far the hardest part of this class for sure, but it is worth a substantial amount of your grade as well. So maybe think about how you prepared for this quiz and what you can do moving forward. One thing to keep in mind is that the way the quizzes are submitted, that I have your answers. So if you want to know exactly which ones you got right and wrong, we can just check in next week in lab or during open hours. With that in mind, your current class grade is available in Blackboard. So you can go into Blackboard and see what your letter grade is as of right now. So including your lab work to date and these 2 quizzes. If you have questions about that or concerns, you can let me know. Sound good? Cool. All right. Wednesday on your way out of class, I ask you the question, with what bones does the tibia directly articulate? Here's a diagram of an anterior view of a right lower limb. You can see the tibia and the fibula there. The correct answers are the femur. So of course, at the knee joint here, we see the proximal end of the tibia articulates with the distal end of the femur, and that is our knee. We see also the fibula, and remember we have a proximal joint between the tibia and the fibula, and a distal joint down here in the ankle. Remember, those are very fibrous joints. Those bones are tightly bound together. You have this interosseous membrane that's kind of holding them tightly. So there's not a lot of movement between either of the articulations between the femur and, between the tibia and the fibula. And finally, we have the talus, which of course is the largest, not the largest, but the most superior of your tarsals. And this is the tarsal that interacts with the tibia at your ankle joint. Remember, I asked you to know the names and be able to identify 2 tarsals. One of them is the talus, the other is the calcaneus. Notice that a good number of you put patella. This is tough. I'm going to say no. The tibia doesn't really directly articulate with the patella, and I didn't cover this explicitly in class, so I want to mention it now. You can see here the patella really articulates with that anterior face of the femur there, and you can see on the diagram here, the patella is not necessarily right over the joint so much as it's right over the distal end of the femur. So if I had to say whether or not the tibia directly articulates with the patella, I would say no, but it's important to note the patella is still an important bone in your knee joint, of which the tibia is a part, if that makes sense. Sound good? Okay, good job with these ticket out questions. These are really helpful, I think, for hopefully for all of us to kind of see what is just make sure we have these concepts clear and to just review things. I kind of like this format. So let's go back to the appendicular skeleton. I just have a couple slides here to talk about some disorders of the appendicular skeleton. One is called hip dysplasia, and this is simply when the head of the femur slips out of joint of the acetabulum. And you can see an example of that here in a radiograph. You can see this is an anterior view, so this is someone facing you like this. So this is the right side, the left side, and you can see here how that femur is kind of looks like it's kind of I guess displaced. Now, looking at this radiograph, do you think this is an adult or a juvenile? I heard juvenile. Yeah, it is. And why? How do you know it's a juvenile? Say again. Go ahead. Yeah, exactly. These coxal bones aren't fused. You can see the pubis here, and you can see how it's not completely fused with the ilium up there. Remember, early in development, those coxal bones are 3 separate bones, and they fuse later in development. And so because of that, remember those 3 bones come together and form the acetabulum. Younger folks are more likely to experience hip dysplasia because that joint isn't completely fused and solid yet. So you see this, you can see this in injuries in younger kids sometimes, like toddlers and stuff like that. Fortunately, at this age, also those bones are flexible. They can relocate the bone and it will heal up and generally be just fine. The other disorder I want to talk about is something commonly called clubfoot. This results when the bones form such that the soles of the feet are turned medially. We see this and it's congenital, and so we see it in newborns. And again, with corrective braces or possibly even serious cases surgery, it can be corrected as well. But obviously, if this limb continues to develop, with the foot turned medially like this, it can be very difficult to walk and things like that. And you'll see cases of this sometimes where it's not corrected when someone's young. They grow up and essentially people can basically learn to walk on this part of the foot. So they'll grow up if this is never corrected and they'll be putting the pressure on this side of the foot rather than the sole of the foot, which obviously can create a lot of kind of mechanical problems. Go ahead, Julia.
They use like the braces. It's because of the club foot, or
it could be either one, probably more likely something like clubfoot or even something like bowed legs or something like that. So anytime that those limbs don't form don't form properly, you can have braces that help those bones kind of develop in the proper pattern. Yep, so it can be any number of things, I guess, to answer your question. These are just 2 examples. Finally, I want to talk about how the appendicular skeleton changes throughout life. What I want to illustrate here with this figure is how the proportions of your body change. And so here we have kind of a typical person throughout development from newborn to adult. And we have them scaled so they're the same height. What I want you to notice is starting the relative size of the head. When you're a newborn, your head is enormous compared to the rest of your body, whereas the time you're an adult, your head is much smaller proportionally. Also, the lower limbs are much larger proportionally in an adult. You can see here that the hip joint is about at this white line. And if you go down to the newborn, you can see that's actually kind of where the newborn belly button is. So you can see how the proportions change. The head becomes smaller. The lower limbs grow faster than the trunk. So they compose more of your height in older age than at younger age. And by around 10 years of age, your upper and lower body ratio, so essentially the height above and below your waist, is about 1. But then as you get older, that changes such that you have more height from your lower limbs compared to your torso. And that's all I'm going to say about that. So human anatomy in the news. This one's cool, actually. I was really fascinated by this. I put a link to this in your class program for the last couple classes, so you may have seen this already. So in the knee, there is in your knee joint, there is another sesamoid bone in addition to the patella that is called the fibula. And so here you see some radiographs. This is, well, let me ask you this. Is this an anterior or posterior view of a knee joint? Posterior, right? You can't see the patella anywhere. You can see these two big condyles of the femur, so you can tell it's posterior. Is it a right or a left knee joint? Right, yep, because you can see the fibula here. Fibula is always left, right? So this is looking at your knee from the back, and you can see these little sesamoid bones. So this is a radiograph, so they look like they're floating, but of course they're embedded in ligaments, as sesamoid bones are, and they are in the back of the knee joint here. And so what's particularly fascinating is that researchers did a study, and they found that this sesamoid bone, which is this bone that's just posterior to the lateral epicondyle of the femur, as I mentioned, about half of us modern people have it, meaning people living today. So probably about half of you have one of these little bones. But about a little over 100 years ago, around 1900, less than 10% of people had this little sesamoid bone. So you remember at the beginning of the unit on the skeletal system, I said that you have about 206 bones, but I said about, and I said plus or minus a couple. This is why. Some of you might have this on one or both of your knees, so you've got 208 bones. Some of you might have this on none of your knees, so you have 206 bones. So it does vary. Some of you might have this on one knee and not the other. And the researchers aren't actually sure why this might be. One thought is that it might be due to increased pressure on this joint because people now are larger than they used to be. We are generally much, much taller and much, much heavier than folks were 100, 150 years ago. And as I've emphasized over and over again, your bones develop in relation to the pressure that's put on them during growth. So we saw an example of this we talked about astronauts in space that lose bone mass because there's not subject to these constant forces of gravity. In this case, it's thought that the extra pressure on this knee joint has kind of prompted more this particular sesamoid bone to become more prominent in the population. And there's a quote from the article, I'll have it up here. The fibula may behave like other sesamoid bones to help reduce friction with tendons, redirecting muscle forces, or, as in the case of the kneecap or patella, increasing the mechanical force of that muscle. Or it could be doing nothing at all. And I like this quote because basically they're just guessing, right? There's a whole bunch of things that it might be doing, or it could just be kind of a random thing that's not directly related to anything. So a good example of sesamoid bones, and a good example of how we're still learning new things about human anatomy all the time, even though human bodies are very well studied for thousands of years. Questions about this will not be on your exam. I will save that for the next unit again, because they're covering this today. It will be on subsequent, probably quiz number 3. I'll have a question about this, but it won't be on your exam this weekend. Cool. Any of you know if you have a fibula? Have you seen like x-rays of your knees? I'm curious. I have no idea. It's like a mystery right now. Like, do I have a bone right here? No, I don't know. Did you have a question, Allie?
Yeah. Is there like anything in this that talks about like genetic backgrounds? Like I'm curious if this is just like if there's like a genetic group that's developing in a higher level, or if it's like the US versus different countries.
Yeah, great question. I need to go back and look at the original article. If I remember, it was based on people in the UK, but I'm not 100% sure on that. I think it's in the link. Check out the link to the article. It tells you what population they surveyed. And I think it was focused on populations for which they had medical records or kind of evidence historically, but I don't remember off the top of my head. But that's a super important thing to ask. Like, is it different in different populations? But go ahead, Veronica.
Exist when you're born, or is it like they develop?
Good question. In most cases, these will develop as you grow and as there's additional stresses on those ligaments and those joints. Could you be born with them too? I don't think you would, but I'm not 100% sure that you'd be born with these. I think they develop later. It's kind of like other sesamoid bones as well. Cool. Well, with that in mind, let's go ahead and start talking about some of these joints. So joints are also referred to as articulations. Those words are synonymous. And we can call this arthrology if we really want to get technical and talk about the study of joints. So here you have a nice view. I'm not sure what kind of imaging is used for this, but a knee from the medial side, you can see the patella. And this is a great example, actually, of what I mentioned earlier about how the patella really articulates the femur, not the tibia. You can see that there's no direct articulation between the patella and the head of the tibia here. Instead, it does really just slide over the anterior face of the femur. So let's talk about joints. Joints we're defining as locations at which rigid elements of the skeleton, bones, or perhaps cartilage meet, and we classify them a couple different ways. The first classification system is a functional classification, which describes how much movement they permit. And I'm going to tell you 3 kinds of joints classified by function and range of motion. The first is what's called synarthroses or synarthritic joints. These are joints that are immovable. So for example, the sacroiliac joint, the joint between your coxal bones and your sacrum, there's not movement there. Another great example is the bones of your skull. Your skull is composed of a whole bunch of different bones, but they're not moving against each other, hopefully. So those are called synarthritic joints. Amphiarthritic joints or amphiarthroses are joints that are slightly movable. So these might be something, for example, let's think of an example here. The joints between your ribs and your sternum, for example. There's a little bit of motion there, but they're not super flexible. We see some more examples of those in the axial skeleton as well. And finally, we have diarthritic joints or diarthroses. These are your freely movable joints, and they're common in your appendicular skeleton. So this is, chances are, when you hear the word joint or articulation, this is what you think of: your shoulder, your elbow, your wrist, your toes, or your finger, your knuckles of your fingers, your knee, etc., etc. So functional classification based on how much they move. We have synarthritic, no movement; amphiarthritic, just a little movement; and diarthritic, lots of movement. Notice here that diarthritic joints are all synovial joints. That word is new to you, and synovial joint is a kind of joint that we describe based on its structure. I'm going to talk about that next, but I want to make the connection that all of these diarthritic joints that are freely movable have the structure of our synovial joints in structure. So this is your functional classification. Let's talk about your structural classification. This is when we define joints by the actual kinds of tissue that compose the joint, that bind the bones together, and whether or not there is a kind of what's called a joint cavity between those bones. And so the first is called a fibrous joint. These are when joints are connected by dense connective tissue or fibers, and they tend to be immovable, synarthritic, or only slightly movable. So again, this is something like the sacroiliac joint between your sacrum and your coxal bones. They're really bound tightly by these fibers to keep them tightly together. Another good example of this might be the joints between your tibia and fibula I mentioned. Remember those 2 bones of your lower, your zygapodium of your lower limb? They're tightly bound together. And those are amphiarthritic joints. There's a little bit of give there, but not much. We have cartilaginous joints. And so this is when there is some movement, but not much again. And these, as you might guess, are bound by cartilage. So a good example is the hyaline cartilage that connects your ribs to your sternum. Again, I'll use that example. And that provides a little bit of movement, but not much because that cartilage kind of binds everything pretty tightly. Not quite as tightly as the fibrous tissue, but still not a lot of movement. And finally, we have this word synovial, and this is what we'll spend most of our time talking about. This is all of your diarthritic or freely movable joints are synovial joints. And these joints have a fluid-filled cavity filled with something surprisingly called synovial fluid that allows those joints to be to reduce friction and to provide a greater range of motion in those joints. And so your diarthritic joints are all these synovial joints. And this is when we looked at the video the other day of cracking your knuckles, for example, it's this synovial fluid in which pressure is released to form those bubbles that create that popping sound. I'm going to just pause here, make sure you've got your notes. All this talk makes me want to crack my synovial joints. So I said synovial joints are freely movable and they can be moved in different ways. So I want to talk about 3 different kinds of movement that can occur in these synovial joints. One example is a gliding joint. So this is when bones actually slide across the surface of one another. So you see in the carpals of the wrist, when you move your wrist laterally like this, those carpals are sliding against each other to allow that movement. Another good example is some of the rib articulations with your sternum. I mentioned that some were cartilaginous joints. Some are these synovial joints that provide even more greater range of movement. We have angular movement, which is probably, again, what you commonly most commonly think of. And this is when technically the movement changes the angle between bones. So this is something like flexion at the knee, flexion at the elbow, flexion of the phalanges, where you're moving one bone in relation to the other across a single plane. And finally, we have rotation, which is just what it sounds like. You're moving a bone around its long axis. So you can rotate your hip joint, for example. If I turn my foot medially or laterally, you can rotate your shoulder joint, rotate your wrist, you can do all kinds of rotation. We're going to do some of this in lab on Tuesday. We're going to play a really fun game of Simon Says, where someone's going to be like, rotate your leg medially, your hip joint. And then you get to do that and make sure you understand these anatomical terms. You know that Simon Says is a really fun game to play. So those are the 3 kinds of motion I want you to know for synovial joints. And then let me just see one thing in my notes here. I got a little more here. Let me talk about this just for a second. I'm going to back up and talk about your fibrous and cartilaginous joints, just a little bit more of an overview of those. And then I'm going to jump back. Actually, let me skip this. All right, I'm going to actually change the order here of the slides, and I'm just going to continue talking about synovial joints since we're talking about it now. As I mentioned, again, I'll say this, that all your synovial joints are diarthritic, meaning they provide a great range of movement. And you can see what kind of a generalized anatomical structure of one of these synovial joints is here. What I really want you to take away from this is that we have this fluid-filled cavity that's filled with synovial fluid. I think this came up in the knuckle cracking video, that it has the consistency of like an egg. If you ever cracked an egg and seen, it's kind of like this. It's a liquid, but it's really kind of gooey and viscous. And it acts as a lubricant. What it does is reduces friction, so those bones can glide or rotate or bend against each other without actually coming in contact and rubbing together. And the synovial fluid is surrounded by this, well, actually, let me back up. There's articular cartilage at the ends of the bones, again, that are super slick, and they actually produce some, they actually contain some of the synovial fluid. And so they're really smooth and slick, and this is hyaline cartilage. And then we have this membrane where synovial fluid is made and contains it, and this is a kind of connective tissue. And then we have a tougher fibrous layer on the outside that kind of keeps everything together. We'll get into the anatomy here a little more detail in lab, but I wanted to just present that and give you the general idea that basically you have this cavity that's bound by this different kinds of connective tissue that contains this fluid, and it's super flexible, as you know, because it needs to be, because it needs to provide that range of motion. And so we have I have a diagram of it here. We can also see what this looks like on a cadaver. For example, this is a shoulder joint. You can see this fluid-filled cavity right here. So this is between the head of the humerus and the scapula here. And you can see that there's a space that contains this fluid. You can see the hyaline cartilage covering both bones at the joint. Just a little more detail about synovial joints. There are a lot of blood vessels and nerves associated with these joints. And what's cool is we don't necessarily think about it consciously, but the nerves associated with these joints are constantly delivering information to our brain about where those joints are in space. So without looking at my arm, without feeling my arm, I know if my arm is flexed or not, or other examples, because there's actually nerves in that joint that deliver that information or detect pain and provide that information to our central nervous system. I said they have a rich supply of blood vessels. What's really pretty cool is that they're actually, the way these blood vessels are structured, we'll talk more about this later in class, they're kind of redundant because when you move your joints in a certain way, you can actually pinch some blood vessels. And so there's multiple blood vessels going through the same place so that some of them are pinched. This area can still get blood. And these blood vessels also provide the basis for the synovial fluid. Basically, that's filtrate from the synovial fluid, filtrate from the blood, which is when liquid elements of the blood are allowed to escape from these capillaries, but bigger elements like blood cells and proteins and things like that stay in the blood. And that kind of forms the basis for the synovial fluid at the joints. And last bit of information, I'm not going to get into this level of detail, but the synovial fluid contains something called glycoproteins. And these glycoproteins provide some of the lubrication of that joint. This is what makes it this kind of gooey consistency. And we can see a great example of a synovial joint, again, in your jaw. We haven't talked about the bones of your face and your skull yet, but this is your joint where your mandible is connected to the rest of your skull. And so you all know this joint really well. You can feel it here just kind of anterior to your ear. You clench your jaw or open your jaw. You can feel right in here moving quite a bit. This is a really flexible joint that allows a great range of motion. You can move your jaw laterally. You can move it up and down, obviously. And it's a good example of a synovial joint. And the takeaway message here is I just want to show you another example of it, showing this joint cavity where you have these synovial membranes surrounding this pocket of synovial fluid. And again, the bones, in this case, the bones of your temporal bone and your mandible are covered again by this hyaline cartilage at the joint. I want to talk about, Yeah, okay, let's talk about these as well. So another aspect of the synovial joint I want to talk about are two other structures called bursae and tendon sheaths, which are kind of the same thing, just in a different shape. So these are sacs of synovial fluid that occur in synovial joints. And again, they act like this lubricant to reduce friction, but they have two basic structures. We name them differently based on their structure. We have what's called a bursa, which is like a flattened fibrous sac. So imagine if you had a water balloon and you filled it up just a little bit with water and let it sit, it would form like this kind of disc shape. That is a kind of bursa. And then we have a tendon sheath, which is basically when you take that sac and elongate it and wrap it around a tendon. And that again helps to reduce friction between that tendon and other tissues at the joint. I'm going to show you, I think this actually I don't feel, let me show you a diagram of this. I think that will better explain it. So we're going to go back to the shoulder joint here. You can see an example of a bursa between the acromial process of the scapula and the rest of the joint here. You can see a tendon sheath. It's basically just a stretched out, elongated bursa that's wrapped around a tendon. In this case, the tendon that attaches the biceps to the scapula there. So you don't need to worry about all of the terminology here. What I want you to take away from this is this bursa and this tendon sheath, and know that they're basically the same thing, just different shapes of a sac filled with synovial fluid. You hear about this, you hear about something called bursitis often, which is when these sacs get swollen or infected. So people, for example, might suffer from bursitis in the knee. In that case, then the sac becomes swollen, it puts pressure on the joint, it makes movement both painful and limited. And that's the inflammation of this bursa. Man, I should have worked in some activities today. Take a breath. I'm just cranking through this stuff. Usually I kind of intersperse it with some things, but I didn't plan that today, so I apologize. Go ahead, question, Kylie, break it up for us. This one?
No, the one like
This one?
Yeah.
Yeah. Julia, question?
Yeah, I'm gonna go.
Okay. No, nothing.
Like the joint,
Mm-hmm.
and the sex, like what is like, I don't know, because I always felt like the joint was kind of the sex, like the, like. I don't know.
Yep. No, that's a great question, actually. Let me make sure I've got that clear. So the joint is going to be this whole structure. The joint includes the bones, the hyaline cartilage, the connective tissue, the synovial fluid, the sacs, everything in all of this whole area, whole anatomical structure. In the joint, we have these different parts of the joint. One of those is these bursa, or these tendon sheaths that are these pockets of synovial fluid. We also have synovial fluid in the joint capsule and these other structures. So all of these things are part of the whole structure.
Okay.
That's a great question. I'm glad you asked it. Gia, go ahead. What causes joint pain? It can be a whole bunch of different things. So, for example, bursitis is the inflammation of these bursae, and that can cause restriction of movement and pain. Something like osteoarthritis is when the cartilage here wears down, and this the articular capsule here, this capsule of synovial fluid, kind of becomes degraded, and the bones can actually rub on each other. So instead of having this nice fluid motion that is with really low friction because of the cartilage and the fluid, this really nice range of motion, instead you get bones pushing on bones, and that restricts movement, and that can be extremely painful as well. You can also get bone spurs, which is when little parts of just what it sounds like, little pieces of bone kind of grow out in weird places, and those can actually bind on each other and cause friction in the joint and rub against each other. So it could be any of a number of things. You can also get inflammation of the tendons and ligaments in this area. And if those get strained, that can cause pain as well. So for example, I always give this example a lot in class, but like a baseball pitcher that puts constant strains on those tendons or ligaments in the joint. So it could be a whole bunch of different things. It could be, yeah, it could be just a acute injury that can heal up with rest and time pretty easily, or something like osteoarthritis that like there's really no cure for it. Once that cartilage is gone, it's kind of gone. You need to either live with it and manage it, or replace the joint in a lot of cases. So yeah, so a whole bunch of different things. And to your question too, it's good to think about how complicated this structure is, and all of these different parts, and it's constantly moving and flexible and very dynamic. And so you have this complicated structure that's also constantly moving. There's lots that can go wrong in that sense, and thinking about that, it's amazing that they don't go wrong more often, that generally most of our joints are working great most of the time, and we're not even thinking about it, that's kind of the incredible thing to me. That's your question? Yeah, good. Jada, go ahead. Yeah, that's it. Well, you're actually overstretching the tendon itself, which can in turn put pressure on the tendon sheath. Yeah. But yeah, you're basically overstretching the fibers in that. And that can again be painful, but that's going to heal up. Generally speaking, unless you severely pull it or tear it, that will heal up with time as well. And rest in ice and all that good stuff. Yeah, go ahead.
The arthritis thing, is there a way to prevent that?
Is there a way to prevent it in I don't know. I mean, generally, in the case of osteoarthritis, there's things that you can do. So for example, in your knee joint, if you're severely overweight, that's going to increase your chance of osteoarthritis in the knee because you're simply putting more pressure on that joint every time you take a step. So there's things in terms of kind of general health that will reduce your risk of that. But in some cases, it just deteriorates without really us. I'm a good example of that. Like my hip, when I went to the doctor and they're like, oh, you have the hip joints of a 70-year-old. And I was like, why? And they're like, well, I don't know. You know, sometimes it just happens. It could be genetic. It could be other factors that like, I don't know. I blame my mom for that. I just told her it was her fault. She shouldn't have yelled at me so much when I was a kid and I wouldn't have had knee surgery or hip surgery. So that's, you could always just come back and blame your mom. Moms like that kind of thing. Good. Great questions here. Let's see what time we got. Okay. We got a few more things and we can wrap things up. Let's talk about, I want to talk about, so now we're getting into it here. We talked about how joints can be classified based on functionality. So in other words, how much movement they provide. So that's your synarthritic, amphiarthritic, and diarthritic joints. Now I want to break down diarthritic joints into 4 functional categories. So these are diarthritic or synovial joints, and we can break these down into the number of body axes across which movement occurs. And I'm just going to do this. We're going to explore this in more detail in lab. So I'm just going to put these up and talk about them briefly. Non-axial is simply movement that can occur kind of in any direction. Uniaxial is when things can only move in one way. And so a great example of this is this first joint between your first and second phalanx in your finger. You can only move this joint in one plane, right? You can't move your fingers side to side at all. It only moves in one direction. So this is a uniaxial joint. Biaxial means it can move in 2 directions. And so a good example of this is going to be the joint between your metacarpal and your first phalanx of your index finger. You can move this finger side to side or front and back. You can move it across a couple different planes. And multi-axial is when it can move in all directions. So your shoulder joint, you can move your shoulder front, back, up, down, left, right, all that good stuff. So we can categorize them based on this movement. We'll talk about this more in lab, and some of your reading in the textbook gets into this in a little more detail. Just going to skip ahead for 1 second and see what else I have. Okay, that's actually cool. Okay. I forgot just, yeah, actually, that's perfect. We'll probably end a minute early, but that's okay. I've just got a couple more slides for you. One more slide on synovial joints, and then I want to bounce back to cartilaginous and fibrous joints for a second. Go ahead, Gia. So non-axial would be something like in the gliding movement in the carpals of your wrist when you move it. They're not necessarily, they're just kind of moving in whatever direction around each other. It's not necessarily restricted to a certain plane of movement. And you'll see lots of examples of this in lab. Actually, not lots, because there's not that many examples, but you'll see some more examples. Okay, so let's talk about synovial joints. We talked about how they provide this movement, but we also need structures that allow them to maintain stability and not simply just fall apart. And so there's 3 structures that I want to talk about in this regard. The first is the articular surfaces. And so in general, these don't play a major role in increasing stability, but in some cases, they're really important. And so some examples include your hip joint. So again, here we have the cup of the acetabulum and the head of the femur, And the way those two fit together provide great stability in that joint. We also see examples of that in the elbow. You have the olecranon of your ulna articulating with your humerus. In your ankle, we have the lateral and medial malleoli, those two kind of bony clamps formed by the tibia and the fibula that provide stability to that joint. So in some cases, although there's only a few examples, the actual shape of those articular surfaces or the bones contribute to stability. Your ligaments are super important. Ligaments are this tough type of connective tissue that binds your bones together at the joints and prevents them from overstretching, basically. Now, ligaments have some flexibility, but only a little bit. And so they provide, they're more for providing stability than flexibility. And finally, very importantly, your muscles contribute to the stability. Low muscle mass can contribute to increased injury at the joints because those muscles surrounding the joints actually help hold those joints in place. So a good example of this is this big deltoid muscle that goes over your shoulder. If that muscle has good tone and is in good shape, it's going to contribute to the stability of your shoulder joint. When those muscles become weak, that's when you lose stability in the joint and can increase the risk of injuries. And so this is true in other places as well. I mentioned the shoulder, your knee, somewhere you don't think about too much, the arches of your foot. So another good reason, kind of go back to your question earlier, Drew, about what can be done. You asked about osteoarthritis, but in general, joint health, this is a good example where overall level of fitness is going to help contribute to reducing the chances of some of these mechanical injuries in your body. I'm going to back up and just say a couple words about fibrous and cartilaginous joints. Yep, I just have a couple slides here, and then we will wrap things up. Going back to fibrous joints, so remember, fibrous joint is a structural classification. We had cartilaginous, fibrous, and synovial joints. Fibrous joints are closely bound together, and I want to show you some examples of these. One is called a suture. So these are the only place you find these in the body is between the bones of the skull. So again, these are very short fibers that bind these bones together very tightly. We also have something called syndesmosis, which is when the ligament is holding those bones together. So I mentioned, for example, the joints between your fibula and your tibula. They're really tightly bound together by these ligaments. There's not a lot of motion going on there. And finally, one other cool joint we don't think about as a joint, something called a gymphosis. And you find this only in one place in your body, well, one area in your body, and that is your jaw. So both your upper and lower jaw, your teeth are bound by something called a periodontal ligament. And this is a tight joint to hold the tooth in the socket of the bone of your mandible or your maxilla, depending if it's a lower or upper jaw. So 3 kinds of fibrous joints. Again, these are joints that allow little or no movement, and gymphosis only in the teeth, sutures only in the skull, and syndesmosis in a couple places in your body. A good example is the tibia and fibula. Also, the distal articulation of your ulna and radius. The proximal articulation, of course, has that cool pivot joint between the radius and the ulna. And I've got one more slide for you today. This is cartilaginous joints, something called a synchodroses or synchodrosis singular. And this is when these bones are connected by cartilage. Functionally, they're synarthritic, so there's not a lot of movement. A good example, and I mentioned this briefly in lab, is that these epiphyseal plates or growth plates, those are technically joints until they fuse. And that's a good example of 2 bones bound tightly together by cartilage such that they don't move. We also see an example of this, your first rib and your sternum. There's not a lot of movement permitted by that kind of cartilaginous joint. So we've got this first rib and sternum is this cartilaginous joint that it doesn't allow movement, but your other joints of the ribs with the sternum are in fact synovial joints that allow a bit more movement. And we have one more type of cartilaginous joint. Can anyone guess what this is? It's come up a bunch of times in class. What's that? Yes, exactly. Fiber cartilage. Nice job. These are called symphyses. We learned, of course, about the pubic symphysis. We've talked about a lot. And of course, the fiber cartilaginous joints between the vertebrae and in your back, in your spinal column. Yeah, as I mentioned, they're slightly flexible and they provide a lot of strength with some flexibility there. So these symphyses. Fiber cartilage is and cartilage. So that is a lot on joints. I just want to reemphasize that we will recover all of this will be discussed in lab this coming week as well. So if it feels like a lot right now, just know we're going to go and revisit everything this coming week. You get a chance to explore this with our skeletons and other models and do it yourself as well. Check out how all those joints are moving. And with that in mind, I'm going to wrap things up here with a reminder that we do not have class on Monday. So don't meet here on Monday. I will see you all again next week, Tuesday. Your exam is open. And I realized that I have the exam ready to go. There's no reason why I couldn't open it earlier to give you a little more flexibility. So I'm actually opening it at 7 a.m. on Sunday instead of Monday. I had originally said Monday, but I thought, well, there can be no disadvantage to giving you more time to do it. For some of you, it might be easier to do on a Sunday than a Monday. So I'll just leave that to you as best fits your schedule. But it will be open from 7 a.m. Sunday to 11 p.m. Monday. Go ahead, Taryn. It is. Yes, I'm glad you asked that. So the way it's set up is I designed it that I think it will take about 50 minutes. Blackboard has a 70-minute timer. Once you start it, then that 70 minutes starts rolling. So you can't start it and like pause it. So make sure you give yourself some space to do that. Again, I want to re-emphasize if you have technical difficulties, there is one question I'm going to ask you to draw a picture and upload it, for example. Please don't fret, just communicate with me and we will settle it. I don't want anyone to get stressed out by that kind of thing because I know that happens. I will not be here on Monday, so I'm not going to have open hours on Monday. With apologies, I won't be available for Monday. Question, go ahead.
Lab room on Monday?
Great question. Yes, the lab room is open. I think the hours are 8 a.m. to 6 p.m. every day. And yeah, you can come in Monday and study. And I encourage you, remember, you do have your lab quiz on Tuesday still as well. So you want to check that stuff out. And that's kind of why I wanted to give you the extra flexibility with the exam on Sunday too, knowing that you have the lab quiz this week. Any other questions? All right, Friday Venn diagram. Thanks, everyone. Have a great weekend. And I will see everyone on Tuesday.